Prior to coming to New York University, he was the Sidney Kaplan Professor of Bioethics at the University of Pennsylvania, Perelman School of Medicine in Philadelphia, where he created the Center for Bioethics and the Department of Medical Ethics. Dr. Kaplan has also taught at the University of Minnesota, where he founded the Center for Biomedical Ethics, the University of Pittsburgh, and Columbia University. He was the Associate Director of the Hastings Center from 1984 to 1987. Dr. Kaplan received a PhD in the History and Philosophy of Science in 1979. He is author or editor of 30 books and over 550 papers in refereed journals. His most recent books are Smart Mice, Not So Smart People, which appeared from Roman Littlefield in 2006, and The Pen Guide to Bioethics from Springer in 2009. Dr. Kaplan has served on a number of national and international committees, including being the chair of the National Cancer Institute Biobanking Ethics Working Group, the chair of the Advisory Committee to the United Nations on Human Cloning, the chair of the Advisory Committee to the Department of Health and Human Services on Blood Safety and Availability, a member of the Presidential Advisory Committee on Gulf War Illnesses, the Special Advisory Committee to the International Olympic Committee on Genetics and Gene Therapy, the Ethics Committee of the American Society of Gene Therapy, and the Special Advisory Panel to the National Institute of Mental Health on Human Experimentation on Vulnerable Subjects. He recently served as the co-director of the Joint Council of Europe-United Nations Study on Trafficking in Organs and Body Parts. Dr. Kaplan writes a regular column, and very interesting one, I might add, and healthcare issue on bioethics for NBC.com. He is a monthly commentator on bioethics and healthcare issues for WebMD Medscape. He appears frequently as guest and commentator on various other national and international media outlets. And this is a bio sketch, by the way. Dr. Kaplan is the recipient of many awards and honors, including the McGovern Medal of the American Medical Writers Association and the Franklin Award from the City of Philadelphia. He received the Patricia Price Brown Prize in Biomedical Ethics for 2011. He was a Person of the Year in 2001 from USA Today. He was described as one of the 10 most influential people in science by Discover magazine in 2008. He has also been honored as one of the 50 most influential people in American healthcare by Modern Healthcare magazine, one of the 10 most influential people in America in biotechnology by the National Journal, one of the 10 most influential people in the ethics of biotechnology by the editors of Nature Biotechnology. He holds 7 honorary degrees from colleges and medical schools. He is a fellow of the Hastings Center, the New York Academy of Medicine, the College of Physicians of Philadelphia, the American College of Legal Medicine, and the American Association for the Advancement of Science. Again, this is a bio sketch. We are very honored to have you with us, Art. Today, Dr. Kaplan will talk to us about a very interesting issue, which is organ transplant, particularly that of face, limbs, and uterus. So join me in welcoming Dr. Kaplan.
Well, thank you. It's a great honor to have the opportunity to speak here. I appreciate all of the great hospitality that I've had during my visit. I think that's my forward and back, right? And I hope that this topic will prove of interest. I picked it for a couple of reasons. One, it's a topic that I have been writing about a little bit. Two, it's a subject that I have followed for the past 10 years, and so it's one that I have changed my views about. I thought it might be interesting to you to see how a bioethicist working with doctors on a very frontier area of research gets educated, changes his or her own mind, in my case, my mind, about the procedure, and the contribution that you wind up making to the process. I'm going to focus on face transplantation, Some of what I have to say will also apply to hand and limb transplants, and a little bit to areas like uterine transplant. And if that comes up in the question and answer, that's fine. We can talk about those. I should also tell you I've got some pictures that may be a little disturbing of face transplant candidates, just so you're warned. And probably the other picture that's most interesting is I only left the University of Pennsylvania 6 months ago. And so when I got to NYU, they made me get these slides that prove that I am there. So we have big pictures of part of NYU. However, the thing you're looking at there isn't the medical school. It's actually part of the college, which is about 30 streets away from where the medical school is. Some of you know we had a big storm in New York City. It damaged the hospitals. My main hospital, Bellevue, is not back yet. It's still not running. It's been an opportunity to look at some of the issues around ethical issues in disasters and catastrophes, natural catastrophes. And we will certainly hold a meeting sometime this summer to talk about that. But other than that problem of getting severely damaged by the storm, it's been a lot of fun to have the chance to be at NYU. So let's see if I can make this thing move. Do I need to hit that? Will this operate from the button here too?
This is
Or just this mode?
Okay.
So this one?
no, the button is-
Yeah, that's fine too. Like that better.
Yeah.
So, as I said, some of the images that pop up here may be somewhat disturbing, so just so you're forewarned. So, the talk that I want to give breaks into two parts. One is the ethics of doing face transplants. Is it ethical to even do them? When I first learned about face transplantation, my answer to that was no. And I'll try to explain why and what the concerns were that made me oppose doing these procedures. Then I changed my mind, and I'll try to explain why that happened. And that's interesting, and I began to think that it was ethically justified to attempt face transplants. But that opens the door to a second set of questions. What are the ethical requirements for doing face transplants responsibly? So the way the talk will go is I'll try to explain to you first what was bad, what was wrong about doing them, and then why I was wrong about my objections. By the way, this is a very rare moment in bioethics when the bioethicist admits to being wrong, so that alone should have your attention. And then some of the ways in which I began to work with some of the research teams involved in face transplant to address ethical concerns, even if you're going to do the procedure. So you may recognize that lady. She was the world's first face transplant recipient. She's the woman from France. She has had a fair degree of success with her transplant, Elizabeth Denois. She has suffered some bouts of rejection, which you can't tell from that. One of the things she does, which drives her doctors crazy, is she smokes a lot, and that bothers them, which I don't think they thought about when they initially picked this particular person to be the first transplant recipient of a face. But on the whole, it has been a fairly good experience. That's a before, that's an after, and you don't see the damaged face here. You see what she looks like post the transplant. She's pleased with it, more or less, and that surgery probably is the landmark one that set off more discussion of face transplant. I began to learn about face transplants before this operation was done. I began to learn about it because I've been studying transplantation and ethical issues around organ donation and allocation of organs and research on transplants for many, many years. It was the first area I got interested in when I went to Columbia Medical School. It remained an interest of mine throughout my career. And so I know many of the people in the transplant field, and some of them who are working on issues close to transplantation, like your dean, So I've known quite a bit about transplant over the years, and I began to hear rumors from my friends and at meetings that something very different was about to be taken up in transplant. Moving from the world of solid organs and vital organs, hearts and livers and kidneys, to start to think about doing procedures of the external body, face, limbs, hands. These sorts of procedures were being discussed in the early 2000s. So what were the concerns that I had about the ethics of doing this initially, which I published? You can find these papers in some of the bioethics journals. I had some critical comments about face transplantation in the media in the early 2000s and wrote a couple of things in medical journals as well, wondering why this was being done. And the three main reasons ethically are these. First, there were no animal studies of face transplantation. Almost no one had done face transplants in mice or rats or in primates. Normally, when you're going to bring a new procedure to humans, you start with animals. You do that with stem cells, you do that with gene therapy, you normally would be doing it in surgery. You wouldn't try doing face transplantation or anything else, I thought, unless you had successfully shown that this would work in animal models. So you would have to do little mice and little rats and transplant their faces and see whether the immunosuppression worked and see whether function was restored as part of the transplant. Secondly, when you get a transplant, for those of you who don't know, you have to take very powerful drugs the rest of your life, the so-called immunosuppressants. These drugs bring their own problems, serious problems. They cause cancer. They cause kidney failure. They often will lead to medical complications that significantly shorten life. They even damage the organs that are transplanted. So the immunosuppression that we have is powerful, but it leaves the patient vulnerable and in some ways sick after the transplant. When these drugs are used, if it's for a heart or a liver, the patient is going to die. So even though there's a risk that taking these drugs could cause cancer 5 or 10 years later, or that it might damage their kidneys if they get a heart transplant after 10 years, the reality is, ethically, you don't worry too much about the risk-benefit ratio because it's death tomorrow morning versus risks that might take place 5 or 10 years later. So that's why, in a way, the ethics of organ transplant have proceeded even in the face of serious risks associated with the drugs that have to be used. We do take someone who has a terminal illness with a transplant and turn them into someone with a chronic illness. That's the transition. It's not a cure. It's moving from a life-threatening situation to a chronic disease situation when you go on these drugs. Now, what if we're going to use these drugs for someone who needs a hand or a face? They're not going to die. They're not facing imminent death. I thought the drugs are so risky, the chance of shortening life so great, that it would be unethical to use face transplants or limb transplants in anybody because you're risking shortening their life or killing them only to improve the quality of their life, their appearance, in the case of face transplant. Lastly, organ donation is controversial. I know it is in Lebanon. It is in the United States. Many people, however, have signed cards, and we have it on the driver's license in the United States, that you can say you would like to be an organ donor when you die. A lot of people sign that. In some parts of the United States, as many as 60% of the citizens have signed this donor card. None of them, I can say with some authority, has thought about donating their face. But the faces have to come from somewhere. Where do you get them? They're going to come from deceased donors. When we asked people back in 2000, when you signed your donor card, had you thought about donating your face? People said, no. I thought you wanted hearts, livers, kidneys, not the face. In fact, many people said, I'm not comfortable with that. And some even said, if you're going to use the face, then I don't want to be an organ donor. So ethically, here's a problem. We could get faces from cadaver donors who had signed a card, but they didn't intend to become face donors. And if we take their face and it gets in the media, other people are going to tear up their donor cards. We could kill people because there would be no organ to give them because people were offended at the idea that their face might be used in a transplant. So the three issues I had were not enough animal work, too big a risk for an aesthetic, cosmetic improvement, and potential damage to overall public health by losing organs that would save lives because people had not been educated or didn't understand or weren't comfortable with the use of the face. Everybody follow that? So that was the three-part moral argument. And I thought it was pretty persuasive. However, and by the way, the same arguments do apply to limb transplants. In terms of people saying, I didn't think you were going to take my hand, I thought you were going to take my kidney. I don't know about my hand, that makes me uncomfortable. So, immediately, what happened was, because I am a bioethicist who is friendly with surgeons and doctors, I began to get pushback on some of these objections. Some of my surgery friends said, I'm not sure that you are right about your objections. This is a woman who had a face transplant at the Cleveland Clinic. First, some of my friends in transplants said, look, it is not just a quality of life issue. You don't understand. This woman can't breathe. This woman has a hard time eating. This woman cannot make tears, and her vision is constantly impaired. Transplants of the face are not cosmetic only. They aren't that, but they are also functional. And some of my surgery friends or transplant surgeon friends said, look, do you know what the suicide rate is in people who we can't reconstruct their face? It is about 10 times the suicide rate of any other group. People who are severely deformed and disfigured cannot go out, cannot intersect with other people, and they do end their lives both because they're functionally impaired and they are socially completely isolated. This is life-preserving to some extent in terms of preventing suicide, and it is functional, not just cosmetic. They said you should meet some of the people who need these operations. Have you ever talked to them? And I said no. So I did. I met 6 people whose faces were so disfigured that they couldn't be reconstructed by traditional plastic and reconstructive surgery, too damaged. Some, by the way, injured by bombs. That's a common problem in terms of war and terrorism, that face transplant comes up. Some because of severe cancer eating away their face. Some because of birth defects that caused diseases that destroyed their faces. So those are the kinds of people that you're thinking of when you start to think about a face transplant. I went to the talks offered that were starting to happen in 2002 and 2003 by the transplant surgeons. I met people in different programs besides where I worked who were thinking about face transplant talked to my colleagues at the University of Pennsylvania who were thinking about it, met people, and everybody was very responsive. But my objection about quality of life, I came to think of as wrong. That this surgery is more than quality of life. And in talking to people whose faces were destroyed and listening to their problems of sleeping, eating, and having breathing problems, I began to think this is major function. It isn't just looking better. If that's true, then the risk-benefit ratio that I was worried about begins to change. It becomes more justified to offer them the possibility of trying the drugs and the surgery, not only to look better, but to see if they could have function restored. So in that area, I changed my mind. Now, what about the animal studies? Well, when you talk to plastic and reconstructive and trauma surgeons, what you learn, what they will tell you, in fact, what they will tell you, they didn't tell me, they were yelling at me, but they would normally just tell you. They would say, "You're wrong, Art. We don't need to do transplants in mice or primates. We use the same techniques. It's a natural extension of what we do in reconstructive surgery. There's nothing new in the microsurgery or anything that's going to happen that isn't already being done in partial reconstructions of the face. It's the same stuff. We don't have to try it in animals. There's no point. We're doing it all the time in people just partially." So that objection began to fall away. Maybe it wasn't necessary to use animals. Maybe it was simply an extension of techniques surgically that were already in use, and people certainly had used immunosuppression in many transplant recipients. People were fairly comfortable. They knew what doses and how to handle that. So maybe the notion of having to do animal work also was not a good argument against the ethics of doing face transplants at all. That left the issue of the impact on public thinking about where the faces come from, which I'll come back to. But in meeting the people, in learning more of the facts about functional importance to them, learning more about the microsurgery and the techniques involved, I changed my mind. And by the way, this is an important lesson to any of you who are interested in bioethics. It is important to know the facts, but it's also important to have close enough relationships with the researchers and the doctors so that if you get the facts wrong, they can correct them and challenge them. And if you work closely enough, you can learn the facts that emerge or as they evolve in terms of trying out these new procedures. Bioethics and medicine have to be very close friends if they're going to work properly. In this case, some of my objections were not valid, and because I had enough friends in the field, I got corrected and educated quickly about what the real facts were. The skills and knowledge to attempt the procedure are present. You don't need animal studies to do it. I suggested maybe people might want to practice on cadavers. We'll come back to that later. That was a suggestion that was taken, not because of new surgery, but to coordinate the teams. Transplanting a face is one of the most complicated things in terms of having a lot of skilled people at both the donation and in terms of putting it on. And practicing that and getting it organized turned out to be something useful, but no animal studies. And the risk-benefit, I think, shifts and justifies things since it's not just a cosmetic surgery, it's a real surgery, and you have this fact about suicide going on in the background. By the way, limb transplants, just like face, had the same issues. The surgery itself is an extension of what people already do, which is putting limbs back on. It wasn't a new thing that required animal models. Reimplantation of digits and hands even has been done for a while. It turns out that on the limb side, psychologically, hands are close to thinking about the face. If you think of it this way, there's certain parts of human beings that we see all the time. this and these. They're always exposed. And if you have a partner, if you're married, you can try this. You will recognize them by looking at their hand. If you see it all the time, you begin to know what it looks like almost as much as the face. So psychologically, limbs and faces are a little different. Emotionally, most people don't identify themselves by their kidney. A few nephrologists do, but other than that, not many. One of the different issues around limbs, which we can come back to in the discussion, is there are prosthetic devices. And they may work as well as a transplanted limb, and you don't have to take drugs. So, I'll just come back to that in a minute. But the limb transplant discussion was going on in parallel with the face. So at this point, if you're going to be able to do face transplants, if they're not completely unethical to even try, then what is the need? The need is people whose faces are damaged beyond reconstructive surgery. You have a number of different groups who might be potential candidates. There are children with terrible diseases, people who are burned, people who are injured by accidents, and people who are victims of war or terrorism. All are out there as potential candidates. The reason I mention that is, even if you say, let's do face transplants, one of the immediate questions then becomes, on who? Who should go first? So subject selection becomes a very interesting problem. Second, are people willing to do it? Well, of the 6 people that I met, remember I told you I met with some people with severely damaged faces, all 6 said they would do it tomorrow morning. That's how bad they felt about their functional impairment and the cosmetic side of what they were doing. There's no doubt that people with very, very damaged faces are looking for a solution. They will do it. They're eager to do it. There's no shortage of people who want to do it, but it raises the question, are they listening carefully to the risks? We have a phrase for this in bioethics called the therapeutic misconception. When you're doing something very new and experimental, sometimes the subjects are so desperate, so sick or damaged, that they don't want to hear that it's experimental. All they can hear is that there's hope. And all they can hear is that it's going to work. Even if you're saying, this is the first time we're doing it, we don't know. So that is not a problem getting people to say, try it on me. The problem is they're so eager to avoid their situation that they may not listen to the risk and benefit that you want them to understand. The skills and knowledge are around to attempt to do it at many centers, although, remember that French transplant? One could be critical of that because the team that did it was assembled from all over France, came to a central location, did the procedure, and they all went home. There wasn't a standing team of people, and the follow-up care for that particular face transplant patient has been complicated by the fact that there's no team. They had a team to do it, but in terms of the months and years afterwards, she has one doctor who's in Paris and she doesn't even live there. And that's why I think she gets into problems with her immunosuppression. You need to have a standing commitment, not just to do the surgery, but to have the skill and expertise to follow up with your subject and take care of them and monitor them after the surgery. And by the way, partial face transplants instead of whole faces had worked pretty well. That's part of the story, that the skills were there. So we already knew that it was possible to transplant the quarter bottom of the face or some other part of the face and know how to deal with the immunosuppression. Well, one other thing I wanted to check on in terms of overall attitudes was, what did religious groups think about face transplantation? There is no group outside of Christian Science that opposes organ transplantation, no religion. There are certainly some religions that have questions about organ donation, but there are none that say it is wrong or forbidden to accept a transplanted organ. I've looked at a lot of fatwas, I've looked at a lot of theological discussions in different religion. No one says it is bad. But what about a face? A face is clearly tied up with our personal identity. It has emotional and psychological significance. For some religions, we are made in the image of God. Is this something you could transplant? So, just a quick review. When I say Muslim here, I mean Sunni. I didn't look at other branches. But for Catholics, what they say about surgery is if the procedure is done for something that is not considered immoral, such as gender or sex change surgery, then elective plastic surgery is left up to the conscience or prudent choice of the doctors and patient involved. They don't prohibit it. They think that if you were getting a new female face because you wanted to change your sex, that would be wrong. But just to repair the face, it's something that they leave to your conscience, if you will. There's no prohibition or ban in Catholic thinking about this. In the Sunni tradition, cosmetic enhancement may not be permitted on the grounds that you shouldn't modify God's gift to you of your body, but a number of religious scholars have said, look, if it's a cosmetic or surgical procedure that restores function, say a mastectomy or something that happens to you, you can't eat after an automobile accident, then that is acceptable. Well, it might not be acceptable to do a face transplant in this way of thinking if it was purely cosmetic, but it is acceptable if it's restoring function, and this certainly is doing that. So no objection that I can see there. In Buddhism, just to look at one other tradition, some see cosmetic surgery as vain and immoral, but there is no widely observed prohibition against bodily modification, including a face transplant, if you were doing it just for vanity, purely for aesthetics and nothing else. I guess you might get some pushback and opposition. However, no one is going to go through a face transplant purely for aesthetics. It is way too big a surgery, and the risks of the drugs involved. Those of you who are thinking, I know someone who could use a face transplant, they'd look a lot better. That isn't going to happen. That the procedure will never be used electively. It is way too expensive. It costs to do one of these things in US dollars about $700,000 to procure it, install. I mean, it's just off the wall in terms of anything that anybody would do. So the cosmetic side becomes a non-issue. So as far as I know, although I'm open to somebody telling me differently, I don't think there's any objection to this type of functional surgery.
According to the Muslim view, there are two views. The view that you mentioned, and there's another view that is similar to the Catholic view.
Not for an immoral purpose.
Surgery, as long as it does not hurt the human being.
Good. So there are some Muslims who sound like Catholics, but other than that, so it's the purpose that might drive it, yeah. And again, it's not that there are hundreds of fatwas on this or that I found big councils offer. These are individuals, or sometimes I asked somebody and said, what do you think? And they would send me an opinion. But I think generally it's in the right place here. I don't think you're going to get religious pushback against the procedure. This man has one of the birth defects that I was talking about. That's his after surgery. He was done at Harvard. He is very happy with the surgery. His follow-up care has been good. He has not suffered any medical complications, and he has only been done, I think he was done 2 years ago now. So there have been, since the time we were talking about, some successes with the surgery itself. So, remember I said the first step was, is it ethical to do this at all? I came up with some objections: not enough animal work, too risky relative to the drugs, bad impact on public support for transplant and making organs available. 2 of those reasons got knocked out by further understanding of the facts, and I didn't see any religious objection, organized religious objection to the procedure, so it seemed as if this is something that might move forward. That said, what are the problems that one is going to encounter in a face transplant, even if it's ethical to try it? I've already mentioned, the subjects are very desperate, really desperate. I can't tell you how eager the people I talked to were to try this. They wanted to be released from a miserable quality of life and would do anything to get into this study. If we announced tomorrow that AUBMC was going to do a face transplant, they would be flying here to get it done. I mean, that big an interest. Desperation makes it hard for these subjects to hear that it is research. Even with the successes that I showed you so far, it's still research. We haven't had more than 6 or 7 face transplants done successfully. By the way, we've also had some failures, which I'll come back to in a minute. But it's hard for them to hear it. So that's a challenge. Another challenge. When your face is damaged, you are emotionally damaged. It makes it hard to say who's competent to give consent because people are so ashamed of their destroyed face, find it difficult to let their children see them, go out in public, do anything, that they are emotionally compromised. And in society, in all cultures, the emotional significance of the face is nothing like kidney or liver or hearts or corneas, even though some people have emotional issues thinking if I transplant the heart, is something of the person transmitted, or the eye, is that somehow, it's nothing like when people think about the face. When you ask people, would you, I mean, we could ask you, how many of you would be willing to donate your face? So not so many. How many of you might be willing to donate your liver? And that's probably the point. So it's got a different emotional significance, and it has to be part of the discussion both for the donors, the donor families, and the potential recipients. So here's the way I began to analyze this set of issues. The therapeutic misconception problem that exists for potential subjects, donor issues that exist for all of us. What happens if the thing goes wrong, which is managing failure, which I will tell you is a very neglected part of all research activity, but you need to have a strategy if you're doing experimentation or research for what you're going to do if something goes wrong, an exit strategy. What would the impact be on the donor family and the recipient family of the new face, the emotional thing, and what sorts of things need to be handled for long-term care? So getting consent from very emotionally desperate and vulnerable people, we decided in the programs that I was now consulting to, the Cleveland Clinic, Pittsburgh, Penn, other programs, we were going to insist not just on written consent, but on quizzes. We're going to ask the subjects to answer questions that showed that they really understood that face transplant had very real risks, both of the surgery and long term. So we don't just get them to sign a form or have a conversation, we ask them to write down answers to questions. We use quizzes in this group to establish comprehension. We have a waiting period. Once you come in and get evaluated and get told everything and answer the quizzes, you must wait at least a couple of months and then come back and reconsent. The waiting period is there because of the emotional issues. We try to involve people in getting consent who aren't part of the research team, who are neutral about whether this person does it or not, doesn't get paid by the grant that supports the particular face transplant program, someone who has a little more distance, that's usually a nurse or a doctor not connected to the particular program. They don't care one way or another what happens. We're looking to have a little less enthusiasm about the procedure as part of the consent by having someone different get the last consent. I think a lot of you know that institutional review boards or human research ethics committees have to review research proposals everywhere in the world now. We went to the Institutional Review Board. In fact, I've done it personally, tried to talk to them about what the procedure was, told them what my initial objections were, why I changed, what the things were that they should be looking out for at their institutions. There is no problem trying to work with the IRB early. A lot of people don't do it, but there's nothing to say, oh, we have to get everything ready and then send it all to the IRB and let them figure it out. You can work from the time you start thinking about doing something with the IRB, and we asked the IRB to monitor closely, subject by subject, at these different institutions, the subjects, just to see what was going on. So they are watching more closely than they might be. We got a commitment from these centers that are starting to do the face transplants, not the French group, but others, to have a team available for post-surgical care and follow-up. I can tell you in this kind of an experiment, what happens is the surgeons are happy, the face goes on, blood flows, it looks like everything's good, and then everybody goes home. And the patient's spouse takes this person home, and they have to take 12 pills an hour and 6 infusions and watch for rejection. The spouse of the person becomes their nurse. And they often say, I didn't sign up for that. I didn't even know that was going to happen. I thought you were going to put the face on, and that would be the end of it. Having a team commitment to help that family and make sure they comply is crucial to this research. So that's another thing we began to look for as part of who was going to be picked. Remember I told you we had children, and we had people who were burned, and people who had birth defects. We decided no children, not initially. Can't really consent to the risky procedure. More difficult to work with in terms of compliance. Let's prove this on adults. Let's prove it on adults who we think really can pass the quizzes. We are looking for people right now who have family members who understand that they're going to have a lot of work to do. If you don't have a family, you're probably not going to be in the first group of face transplant research subjects. That may not be fair in terms of bias against single people, but it seems a requirement given the follow-up that's needed to make this work. So those were some of the issues that fell out for subject selection as well as subject consent. A much tougher consent process is recommended here by me to the teams than would ordinarily be expected for research. So who can be a donor of a face? Well, we have cards, and I asked many of you, and many said, I don't know about the face. We decided we would not do a face transplant unless we could get a written card saying you wanted to be an organ donor, but, and this is not required by American law, we will consent the family. And if the family says no, we won't do it, even if there's a signed donor card or written directive from the person who died saying they would do it. So we are trying to handle the public concern by saying we are not going to take anybody's face unless the family also gives us permission to do that. And by the way, there's something else that's going to happen in the States pretty soon. I've got some students writing about this. We're going to try and update the organ donor law to include limbs, uterus, face, fallopian tubes, and other body parts. They are not listed in our law, but we're going to try and update that legislation so that no one is surprised or angry or feels that they had something done that they didn't know might happen. We even have this problem for those of you thinking about it. You know, it's possible to take sperm and eggs from the dead. We have just started egg freezing. Sperm donation after death is something that has already been done many times around the world. We need to make the legislation in each country capture whether or not that is to be done. We have a lot of people who are facing a terrible accident. They say, this is my lineage. I want my son or daughter to have a child, and I want you to take their egg or their sperm and freeze it. Now, they don't say who's going to make the baby, or when, or how many. So that whole area is one that requires the same kind of attention that updating the overall organ and tissue law does. So that's how to handle the worry about public concern. We have to take it to the public and let them tell us, I want to be an organ donor, but I want special checkboxes for hand, face, uterus, ovary, fallopian tube, egg, sperm. Or is it all part of a big general consent? So we're going to be working on that, and I think other countries and other parts of the world will be working on it for a couple of years to come. Would we put someone who is obviously an African American, would we put their face on someone who is obviously Caucasian? Comes up. It might make a difference biologically in terms of rejection, just as we sometimes have to pay attention to ethnic and racial groups in matching donors and recipients. We decided we would not do anything that crossed gender and crossed race. Race partly for biology, gender partly because of that purpose issue. It makes it look like you're changing something essential about the person instead of trying to repair something. If you're going to be a donor, when do we approach you about face donation in the family? Well, certainly not until after death, but it is true that, remember, an organ donor of a face is going to be on life support for a much longer time than an organ donor of other organs would be, because it's much more complicated to remove the face and move it. And if you're going to be a face donor, does that mean you can't be a heart or a liver or a kidney donor? It doesn't, but it clearly means that the face has to come before the others, and there's a big gathering around the bed in terms of people saying, I need to save a life, as opposed to what you're doing with the face. So as crazy as this sounds, you need to have a priority system in place for whether or not the person wants to donate a liver before they would want to donate a face. Because face will come first, and it will mean being on machines for a much longer period of time before they're shut off than you would if you just donated a kidney. Obviously, we're going to need some post-donation counseling and support. I'm often asked, will people look like the donor if they receive the face? The answer to that is it depends how much of the face is moved. There are bones, there are fat, and there's muscle. Some people believe you can move less bone and transplant the face and have a good outcome. Some people believe you have to move a lot of the facial bone structure. The more you move of the underlying bone structure, the more you look like the person who's the donor. So it depends. Depends on how it's done, and that's part of the research because no one knows the answer to whether you should go into the face deeply or not so deep. That's one of the research questions that's still out there. And as I said, we are going to insist on family consent. One of the other issues, if you received a face, would you agree not to contact the family whose relative gave you the face? It's one thing to accept a kidney. We keep that pretty anonymous when it's a cadaver donation or a liver. We also have living donations, and people clearly know who got their organ. But with the symbolic issue of the face, we thought it important to ask people not to try and contact the donor family. Even when they see someone perhaps in the media who they say, that looks like my daughter. It's too emotionally disturbing, I think, to the recipient and the recipient's family. So as I said, these were some of the issues that we addressed in terms of recipients and the risks. We tried to pick people who are psychosocially stable and have family support, the best chance of having a surgical success. We probably wouldn't take the woman who got the transplant in France because smoking is not consistent with good management of immunosuppression and compliance. She might not have made the list. We probably would not take people with mental illness. It's not that they might not need a new face, but they're not going to be first in the research protocols. Do they have to have the ability to pay? Well, they don't have to have the ability to pay for the surgery per se. That's probably going to be done with gifts and grants. But remember, I mentioned the strong need for aftercare. If you had a job and you were the spouse, you're probably not going to work for a while. Those are expenses that families are going to have to absorb. So we need to be attentive to whether or not they can get through that. And I told you we decided no for children. Now let me mention this next issue because I think it's one of the toughest ones of all, and without being horrible about it. If you transplant a face and it is rejected, the drugs don't work and the body rejects the face, there is no rescue for that person. The face is going to come off. It is unlikely there will be another donor readily available, and even if there were, putting the first face on in terms of microsurgery ruins the possibility of doing another one. The question, very simply, and you can all think about this, is if the person says, my face is destroyed, this experiment didn't work, I want you, the doctor, to kill me, will you do it? Because you can be sure, given the disaster that a rejected face would be, a patient is very likely to make the request. You need an exit strategy that you have to discuss. You could certainly say to the patient, I won't kill you, but I will remove all life support and let you die quickly. I will remove all life support and give you all the morphine I can think of, which probably will kill you faster. Or in some instances, the principal investigator said, if that request comes, even though it's murder, illegal, all over the world, I might do it. So I won't tell you which one said that, but I will tell you this. If you're going into an area like this and things go wrong, you have to be prepared to let that patient not suffer, not have any options whatsoever if the thing turns into a disaster. And the worst thing I can think of is a failing face transplant. Can't breathe, can't eat well, you have to go onto feeding tubes. Infection would be uncontrollable. It would be an enormous disaster with huge suffering. And if family members are coming by, the whole thing gets to be crazy. Not one program initially, when I talked to them, had an exit strategy. They all do today. All the ones in the States have a plan. It's not all the same plan, but they at least have a plan. If you remember anything from this lecture, if you go into research, remember you need to think about failure and how to manage it. Success is nice. In research, failure is possible. You have to have a plan for managing failure. It's what you owe to the subject. If they're going to let you study and learn on their bodies in highly risky things, you have to come up with a plan to handle failure. There's some risk to family members who watch this. They may have high expectations about how well people will look. They need to be counseled about that. At least initially, all face transplants produce publicity. It's hard to give anybody any privacy. As I said, there are going to be costs, not so much with the surgery, but with the follow-up. And you need a team to help support the person, not just do the surgery and run away. That is a very difficult situation to leave someone who's now got to manage a very complex amount of drugs and medications without having regular team support. So we've seen this is the situation with respect to transplant today. We've had 20 full or partial faces as of early in 2012. Some other nations, China, France, Spain, Turkey, continue to show interest in trying this. The gentleman that you see there, the man who's Asian, he is a failure. His face rejected. He killed himself. Failure is a very real possibility in face transplantation. He wasn't afforded the opportunity of mercy killing, but he did kill himself. His transplant rejected completely. Britain has been mixed in its attitudes about face transplantation. Interestingly enough, they are still arguing about whether the risk-benefit ratio is worth it. My initial objection is still got the British thinking maybe it's not ethical to even do these. So there's at least one place in the world that didn't get past the argument about whether it's ethical to do it at all. So these issues require continuing attention as we move forward. We have to try and let the people involved avoid the therapeutic misconception, the belief that they're going to be cured. We have to have teams, not just assembling an ad hoc group to do something so that you could do it early. The face transplant people need to get the full options and full presentation of risks, including the possibility of failure. No one should be doing high-risk experiments like this without an exit strategy in place that everybody agrees to. I can tell you, by the way, years and years ago, when the first artificial hearts were being put into people and they didn't work well and caused strokes and many other complications, at least one of the early artificial heart recipients asked that the machine be shut off, and no one would do it. That's what I mean when I say you need an exit strategy. Maybe no one would shut off the machine today, but that should be discussed with the subject before they do it. We have donor management, got to make sure that people are comfortable with the consent. I think getting the family permission and the individual's permission is appropriate. We need to update the laws so that people know that if they don't want to do this, they can still be organ donors and they don't have to get involved with face donation. Working with the IRBs becomes very important so that they know what to watch for and how to review these things to assess whether an institution is ready for it. Trying to create someone who can help independently get consent and act more as a subject advocate, not connected to the study, I think is useful with this kind of desperate subject. And we owe it to the subjects to ensure publication. One of the problems with face transplants, and I'll beat up on the French example again, is no publication. Shouldn't be doing research unless you're going to write up the cases. What you tell the subject is, please let us put you in this study so we can learn. Please let us put you in this study so we can contribute to generalized knowledge. That's what the informed consent to research says. If you don't make new knowledge, or the only way to make new knowledge is to put it into print in peer-reviewed journals and at peer-reviewed meetings. Some of the face transplants have not been presented that way. I consider them ethical failures. They didn't transmit what went right from some of these experiments, or in the case of France and China, some of the problems. You have to be able to publish and be willing to publish if you're going to do research ethically. So I hope that gives you some idea of both how bioethics works and some of the issues around face transplants. How bioethics works, hopefully, is by getting the facts straight. In this case, once I understood better what the facts were, I changed my view from no to yes. But even with a yes, there are still a series of issues: how to pick the subjects, how to consent the subjects, an exit strategy, thinking about the public's response to this and updating the laws, making sure a team is in place to follow people, and many, many other issues that still require attention, that a good bioethicist should be able to point out, that a responsible research team should be able to develop an approach to handle them. That's what we're trying to do now in the States with respect to face transplant. I think face transplantation has a future. We will see more of it, but it is something that I think has to be treated still very much as an experiment, very much as something that is innovative, very much as something that requires careful attention to the ethics of what we're doing. Thank you. So I have a question while we're waiting. Does Lebanon have organ donation on the driver's license? No. So if you wanted to be a cadaver organ donor, you have to sign a special document. So the question is, what about uterine transplants relative to the face? The uterus raises some similar questions. One is, taking the drugs and the immunosuppression simply, and I mean that simply, to be able to deliver a child strikes some people as a cost-benefit ratio not worth doing. But again, having talked to some women who really want to deliver their own baby, I think I'm convinced that there is an ethical argument to do this. The good news about uterine transplant is you could take someone off the immunosuppression. Once they deliver the baby, you could take the uterus out. So they don't have to spend a lifetime on these drugs. So in terms of risk and benefit, the rationale for doing it is certainly controversial in terms of, should I adopt a child? Should I hire a surrogate mother to do this for me when that's legal and available? Or why do I have to go through all this just to deliver the baby? But for some women, delivering the baby is part of the process of reproduction, and they very much want to do it. If we get past that, then there are some other tough questions, a little different from FACE, but not all different. One is, how are you going to handle the donor? So mothers want to help daughters. But mothers have older uteruses. Is that the best place to go for a donor? They may be willing, but is that where you want to go? Should we consider cadaver organ donors of the uterus? You could. There's no reason you couldn't procure that along with something else, other organs. It's not part of the system. The few uterine transplants that have been done have come from living donors, but somebody may not have a willing living donor. So the third issue is demonstration of function. There have been no live births from a uterine transplant. So we don't know. You're also exposing the fetus to these drugs in development. That has happened for some people who are on kidney and liver transplants have given birth. It doesn't seem to harm the fetus, but the number of babies is small. So there may be risk to the baby. Transplanting a uterus sounds good, but the amount of force that's generated when you give birth is enormous. It may be that what you're talking about is transplant for a cesarean section. And remember one other thing I mentioned, the exit strategy. If the fetus looks in trouble as you monitor the pregnancy, would you take the fetus out? When would you remove the fetus? Is it when the mother looks like she may be bleeding because the transplant is not working? Would you sacrifice the mom if she said, do everything to save my baby? You've got a bunch of questions about what happens if things go wrong that have to be fully addressed before you proceed. I am less optimistic about uterine transplants than I am limb and face in terms of rationale, risk to third parties, coming up with an exit strategy that works, and whether they will actually function to allow you to do what people want. I wouldn't say never, but I'd say I'm skeptical. I think over on the table, did I send that? I have an article coming out in Fertility and Sterility next week on the ethics of uterine transplant that's over there that says what I just said. It's more ethically critical than I was of face transplant.
Thank you very much. I can see how busier bioethicists are going to be as a result of this. But you mentioned one case of a face transplant that failed and the patient killed himself or herself. Of those that have taken place, I assume there may have been other cases of failure. And how were these handled, if you're aware?
What has been failure in these other cases is partial rejection. Because there have been teams in place and part spouses to help the subject detect the signs of rejection, they have been managed by making sure that the immune suppression dose has been changed. In some cases raised, in a few cases actually a little bit less. There have also been some issues around infection. They have been managed. We have not seen any total disasters of a complete rejection because the early signs were monitored, detected, and very quickly responded to. That's why I said it's important to have a team for follow-up. If you don't have that, you just bring everybody together and then they all go home. You're asking for trouble because if something begins to reject, it isn't detected enough and there's no team to manage it. So that's been the situation so far. I'm not a big number of cases, small number.
I just wanted to ask, in terms of the uterine transplants, most of the ones that have been done, or the 3 that have been done, have been in Saudi Arabia, Turkey, and Sweden. In terms of the rest of Europe and the US, what progress has been made on that issue?
Well, there's certainly teams talking about doing uterine transplant, but I think the ethical issues for the states have said you need to do more animal studies. Remember I said in the case of faces, it was an extension of what had been done. The key question in uterine transplant is, can you get a healthy baby out of a transplanted uterus? And I think the American view and the Canadian view is you need to do this in more animals and see whether they produce healthy offspring. It's not time to try it in people yet. Those experiments in those countries are premature.
Thank you for the presentation. Regarding face transplants, currently there's the trend in stem cell research and biotechnology, nanotechnology. It's been successful in transplanting several organs such as tracheas and inner organs. When it comes to the face, it's not there yet, but it's going to be soon, supposedly. Where do you think the ethical dilemmas about donors and rejection stand at that point?
Well, hopefully the whole field of transplantation will move more toward the use of stem cells. I hate to say this, but because my transplant friends will get mad, but taking organs out of dead bodies and putting a lot of drugs into the recipient so that the organ doesn't reject is not an elegant solution to organ failure. A better solution is growing new organs, either around constructs, plastic devices, or in the case of the liver, maybe just growing back cells, or in the case of the pancreas, just getting the islet cells that make insulin to grow back. In the case of the heart transplant, many people who get heart transplants don't need a whole heart. They just need muscle repair of the ventricle. So that is the future, is stem cells. In the case of something like the uterus, it's more likely that you're going to be able to grow back a uterus or a bladder as a kind of bag-like entity of similar sorts of cells by stem cell research. The face, I doubt. Too complicated, too multi-functional kinds of things. I don't think we're going to see things, or maybe parts of the face, nerves or muscles, but not an entire face grown in the lab. Nobody in this room will live long enough to see that happen. But I do think for things like uterus, yes. The bladder, yes. The esophagus, other organs, absolutely yes. And this sounds like I am advertising for myself, but I am part of the group that's been writing about the trachea transplants with the Karolinska Institute team. We wrote something in the Lancet, and we have an ethics section in that paper on the trachea transplant. We have a new one coming out in the Mayo Clinic Journal, January, with a bigger ethics section on just these issues. But I don't think any of those issues, there are issues and they have to be managed, but I don't think they're going to set back the field in any way. I think the future is regenerative medicine. Probably not going to work for the face or multiply complex organ systems, but absolutely for many, many of the things we're transplanting now. Absolutely. And I think it's a good thing.
One last question.
By the way, if you didn't get a question, I'll just sit over here for a few minutes if you just want to come up and ask something you didn't want to ask publicly because you would embarrass me.
Hi. Just want to ask do you think it's ethical to actually encourage face transplants, face donation? Because I would think you'd get a lot of opposition, probably religious. And my second question, trying to remember. Okay, I'll come back to it.
I don't think face transplant should be part of the general campaign to say, think about being an organ donor. Too emotional, and I think this about limbs, hands, legs, they're too emotional. At present, maybe that will change someday when there are hundreds of face transplants and we're all used to seeing them, but that isn't where we are now. So I think face transplant only should be offered to select people who are dying, who might fit the description. My ideal situation is having the consent of the person before they die, knowing that they're going to die, approaching them and asking if they'd be willing to do this. As an approach to the general public, even though I said we might want to change the law, I wouldn't aggressively go after limbs and faces and reproductive organs too. They're too, you risk killing people because other people just say, then I'm not doing that. So I do think it's dangerous enough that you have to go very cautiously right now.
So what's your assessment of the opposition? So do you think it's really like very strong opposition, or do you think with more awareness people will be a lot more likely to?
It's so cutting edge right now that the opposition isn't strong. But if the more face transplants that are done, the more I think opposition is going to appear. So now it's almost exotic. 5 people, 10 people, you don't have to worry too much that they're going to come after your face. If it starts to move from an experiment to a proven procedure, then I think we'll hear the opposition. But that's still years away, and there's still time, if you will, to adjust public policy so that those concerns can be addressed. But it's out there. It's definitely out there. Every time I do a survey and ask about face, everywhere in the world, very few people say they want to do it. You can see that, and that's in medical groups, you can see that it's likely to be very, very controversial. If you move to reproductive organs, the uterus, the ovaries, that's obviously controversial, and the egg and the sperm, you know. So on that spectrum, the good news is that's a lot of full employment for bioethicists. I like those technologies. Okay, thank you.
Art, thank you very much. This was very interesting and enlightening.